Good morning, everyone, and welcome to our monthly session. SCPRSA is so glad you're here, and we are going to have a really wonderful statewide conversation today on crisis communications, which is such a really instrumental part of what we do as communicators. I'm so excited to see all of you here, and welcome to our friends in Greenville and Charleston who are live up there and down there because we are broadcasting and simulcasting to them today as well. I'm Ashley Dusenberry, and I'm president of the South Carolina chapter of Public Relations Society of America. And I'm so thrilled to have my colleagues from Palmetto Health here with us today. Jay Ham, Tammy Epps, and Shalama Jackson. We're going to have an in-depth conversation about how Palmetto Health rose above the flood, the great flood of 2015. It was just such an amazing time for our community. We saw such strength come out from that, and I'm looking forward to hearing the story of how Palmetto Health dealt with that moment and how hundreds and hundreds of patients' lives were not compromised in any way, shape, or form during that time. One of the things I wanted to remind you of today is we are having a live tweet chat, so be sure to use the hashtag SCPRSA 2016. We will take questions about 8:35 in the room here in Columbia. We invite you statewide to tweet any other questions you may have, and we will pose those to Jay, Shalama, and Tammy at about 8:35. So we will do a quick introduction, and then we'll get started. Jay Ham is Chief Operating Officer for Palmetto Health Richland, and he was previously Vice President of Operations and System VP of Clinical Operations for Palmetto Health. Jay has been a medical professional for 25 years, and he's held several management and executive leadership roles. He earned a Bachelor of Science degree in Nursing and Biology and a Master's of Health Administration from the University of South Carolina. He is a fellow in the American College of Healthcare Executives and a member of Delta Omega, an honorary society in public health. He received the 2015 Norman J. Arnold Alumni Award from the Arnold School of Public Health at the University of South Carolina in recognition for his dedication in the field of public health and for his positive impact on our community. Tammy Epps has more than 20 years of experience in the communications field. She spends her days telling the story of Palmetto Health through media relations, special events, and social media. She's the lead communicator for Palmetto Health's emergency management teams. She has a bachelor's degree in mass communications from Winthrop University and a master's in communications management. She is active in numerous professional organizations in our community. Shalama Jackson is the media relations specialist for Palmetto Health. At the time of the flood, Shalama was the internal communications specialist working with Tammy to keep Palmetto Health team members informed and updated. With more than 10 years of experience in the communications field, she's worked as a reporter at the State and the San Antonio Express News, as well as the South Carolina Hospital Association, where she worked for a number of years. She has a bachelor's in mass communications from the University of Incarnate Word in San Antonio, Texas, and she currently serves as the Carolina's Healthcare PR and Marketing Society board member and is very active in other organizations in our community. Please welcome Jay, Tammy, and Shalama.
Thank you.
Good morning.
Good morning.
One of the things about healthcare that you know is unlike, we say this all the time in healthcare, unlike other organizations, we never close. So we're open 24 hours a day and 7 days a week, and there are always people we're responsible for. And you know, they're at every level. I always tell people healthcare is like highs and lows. So we have all the great highs of life where people are having babies and things have been fixed and people are feeling better. And then the lows of life where unfortunately people are very sick. So when we're thinking about crisis, we were thinking about it in terms of, you know, not only, you know, all the people in the highs and lows, but all the 10,000 people that work for us too. So where were they at the time? You know, how do we get them to work? How do we make sure that we can take care of the people that are very sick? How do we make sure that, you know, one of the things about the flood was people had nowhere to go. So one of the things you do in crisis communications when you're dealing with patients is you try to discharge people and send them home. Well, nobody could really go home because some people had no home to go to, or there wasn't passage. You couldn't get to their homes. So there was a lot of things going on at the time that we had to deal with. Okay, let's see. So this is a quote, and we thought it was really really fitting for this time. Once the storm is over, you don't remember how you made it through it, how you managed to survive. You won't even be sure whether the storm is really over. But one thing is certain, when you come out of the storm, you won't be the same person who walked into it, and that's what the storm's all about. Isn't that awesome? South Carolina was changed by the storm. For those of you who were here during Hugo, we would say that same thing. South Carolina was changed forever by the storm. So we at Palmetto Health were changed forever. We learned some things about ourselves. We learned some things about the people that are around us. And our state came through it, sparkling and shining because we pulled together. But there's so many people who have still been affected by, some people's still homes will never be replaced. I mean, I know some people like that personally. So, we know that there's a lot we learned. You already saw us, so there we are. Some of the things we'll talk about, challenges that we faced that are a little bit different from the challenges that other companies might have faced. Things you'll learn about how we train and prepare. Most companies now have really, most of them have good emergency management planning. Hospitals have more. We are always planning. We have drills, we have monthly meetings at all our hospitals. It's part of what you have to do that's required. But also, we take it very seriously because we understand that at the end of those plans are people and lives. And so we have to be prepared. We'll learn about how we coordinated with local, state, and federal resources, lessons learned from the event itself, and then we'll talk about communications, the communications vehicles we used. Okay, some things about the flood. So we all know that 1 trillion gallons of rain fell over the state of South Carolina on one day. I live in a fairly new house, and I've never had a leak ever, and all of a sudden, my roof is leaking. So like, what? Where did that come from? So that's how much the rain was so intense. There are 40,000 people across the state had no water. It's one of the costliest national disasters in South Carolina history. $1 billion in damage to private property. 20 counties were federal disaster declaration. 500,000 survivors registered, more than $27 million in disasters. And you guys were here, so we like this graph. I love the one about the Rose Bowl in the middle. 130,370 Rose Bowls filled with water. Can you think about how big that is? It's so extreme, enough to end the drought in California. So this is a cool slide. So basically, we were dealing with once in a lifetime kind of situation. And the pictures, you're here, some of the pictures we saw were amazing. Like, that really happened, one of our nurses said in the video. We put a link up to our video that we did about our response. It's too long to show here, but we'd love for you to watch it. It tells some of the personal stories of our team members and things that they dealt with. And so please watch it when you have a sec. But some of the pictures, one of our nurses said that she was going down, she saw a car floating by her. like wait, it's a full car. And then we had patients who were impacted trying to get back and forth from the hospital. So this is a little bit about us. Most important to us, everything we do is about our vision to be remembered by each patient for providing the care and compassion we want for our families and ourselves. We try to do everything that we do at Palmetto Health to treat people like family. So if you think about we're in the flood, and everybody is our family. So we have 12,000 team members who are our family, and at a time I think we had about 1,200 patients in the hospital. So we have a 5-hospital system. We just recently Toomey became part of our family, Palmetto Health Toomey, now in Sumter. So about right at 1,200 beds. Every year about 800,000 outpatient visits, 150,000 ER visits, 55,000 inpatient employees. Our number is bigger now, our employee number is bigger. We are a level 1 trauma center, which is very important during a disaster because the most critically injured people would come to you. So the other things you're looking at is how to do is if you had to change around patients, we couldn't discharge any. So what would we do with the patients that were less severely injured if we had to take in an influx of patients who really needed our help and who wouldn't have been able to go to other places? Of course, we know that transportation was a really big problem. So I like to talk to Jay. He's going to talk to you about emergency management and the cycle that it goes through.
Great. Thank you, Tammy, and good morning, everyone. I'm going to talk a little bit about what we do to prepare for any event that may impact our ability to provide care to you and our community. There are 4 cycles of the emergency management phases that we look at. Preparedness, which is what Tammy talked about. We have to prepare for any type of drill. We call it an all hazards approach. So whether it's a mass shooting like we saw last week in Orlando, whether it's a bus accident or a train accident, or a nuclear incident at VC Summer, we have to be prepared to deal with all of that. So we drill. We drill a lot. We hope we never have to use what we learn, but we are prepared. When a disaster strikes, we have to respond to it. And whether that's bringing in multiple surgeons to address multiple GSWs, or whether it's an accident on the interstate with 50 people from a bus accident, we have to be prepared to do that. How do we get our folks in? How do we communicate with them to let them know that an event has happened, that we need them to respond to the hospital? After the response, we have to recover. We'll talk a little bit about that in a minute. What do we do to recover from the flood? How do we get back to normal operations? And then mitigation. What are we going to do now to try to prevent whatever happened before? So you'll see some of our lessons learned from the flood. There are things that we need to do to be better prepared if this should happen again. Part of our preparedness is we do a hazard vulnerability analysis, and that's basically looking at what are the chances of something happening in the Columbia area that we need to develop our plans around. Is it an earthquake? Is it a hurricane? Is it a severe flood? Is it a tornado? Is it a water outage? Is it an electrical outage? So you look at all these things, you rate them, and you get your top 3 that you try to focus on during the year. We do this annually, and we plan our plans around what are those top 3. Tornado's always in there. There's water. Water has been in there before just because we've had some issues with pipes being broken and water not getting to the hospital. Flooding, our Baptist campus has flooding. If it's a bad thunderstorm, it floods a lot. So what have we been doing to prepare for that? We have an emergency operations plan which tells how we respond to these things. So if a team member needs to know how do we do it, there's a book that you go to, and it really lists the general things that you would do. And then, of course, drills. As I talked about, we are required to drill. We have to document our drills. We drill with many agencies. We drill with the Fort, VC Summer, and we drill with the city and the county to make sure that we're prepared to address any issues. And then the 6 categories that we look at: communication, utilities, safety and security, resources, staff responsibilities, and patient care. Really, those 6 are the things that we will look at. Communication, obviously a big piece. In any disaster we've ever had, communication can always be better. So, and when you see lessons learned from this event, you'll see where communications could have been better. Utilities, now this flood event we're talking about, this is where this category with utilities, you're looking at water failure, you're looking at electrical failure, you're looking at anything that may impact your ability to keep the hospital going. Safety and security, how do we keep our staff safe? How do we keep our visitors safe who come there? How do we control entrance to the hospital? You heard probably from Orlando that they had to lock down their hospital to prevent families from running in and probably interrupting the operation. So you have to control the entrances and exits to your hospital. How do you do that? Do you have enough manpower to do it? Will you get city help to do it? Probably not. The City of Orlando Police could not provide the assistance to Orlando Medical Center just because of what was going on. Resources and assets. What are the resources we need? You'll hear that we had lots of bottled water in our warehouse stock. That's part of our planning in case something happens. We need to be prepared to sustain ourselves for 96 hours is what the Joint Commission requires. So what does that mean? You need water, you may need food, you may need cots, you may need medical supplies. So we go through that and decide what do we need, can we sustain ourselves for 96 hours? Staff responsibilities. What are your responsibilities when there is a disaster? Do you need to be available? Do you need to go to a computer, or do you need to check in? Do you need to call a phone line? How do we communicate with you in case we need you? And then patient care. obviously that's why we're there. So patient care is huge. And you heard Ashley say, you know, we were able to get through this flood without really causing any harm to our patients, which was a big deal. Okay, pre-crisis. I'm going to go, this normally takes about an hour and a half to get through, so I'm going to condense a lot of it. So pre-crisis, we had started looking at the weather forecast. This is what we do. We start monitoring stuff when there's a disturbance in the Atlantic. We may start looking at it. We don't try to freak people out, but we need to be prepared. We can't wait until the day before and go, oh my gosh, there's a hurricane coming. So we started listening to the forecast on that Wednesday, talking about a catastrophic flood. So we start pulling our team together. Okay, what does this mean? What do we need to do? What do we need to prepare? We started really checking the drains on each campus to make sure they were clear so the water can get down. We looked at the roofs of each of our hospitals and checked the drains to make sure they were functioning. Any area that had flooded in the past, we asked those areas to prepare, move computers on the desk, cover them, move anything on the floor off. So we did all that stuff. Obviously, we didn't know what to expect. I mean, we suspected it would be a lot of rain, but we did not. Obviously, I don't think any of us expected what happened. So we got ready, we notified, we actually communicated with our staff that Friday and said, hey, be prepared, the weather forecast is calling for this. We're not sure what that means, but if you're scheduled to work, you need to make sure you can get to work. If you live in an area that's prone to flooding, you need to come to the hospital and stay or move to higher ground and be prepared to come to work. Obviously, we have to keep patient care going. If people don't come to work, then it makes it very difficult for us. And then the people who are already there, like the night shift, get stuck staying there, which is what happened that day. So we have to be very prepared. Initially, I think like most people, we went through Saturday. We were expecting more rain on Saturday. It really didn't happen. So I think people started going, well, this is not going to happen. And if you watched the Clemson-Notre Dame game that night, you knew the rain was here. All right, so we knew it was raining. Went to bed not suspecting that we would wake up to what we did, and I don't think any of us did. And I get a call at 4 in the morning, and it says we've got about 90 leaks in the hospital. We're moving patients from rooms that are leaking to rooms that aren't leaking. We're having water rescues throughout the city. You know, that was big change from when I went to bed at 11:30 or so that night. So we got up. We have people in-house that start assessing the situation. So they were keeping us up to date on what's going on. We put out the all-call and basically said, wait until sunlight to come in. We would hold all staff, notify all staff working the night shift that they need to stay until day shift gets there to be able to take care of the patients. Once we got there, 7:38 in the morning, we obviously go through our checklist. We open our incident command center. Tammy's involved. We're starting to figure out, okay, what do we need to communicate to our staff? Because they need to know what's going on. Now, obviously, they're looking at the news probably. They're seeing what's going on in our community. And we start thinking about, well, what do we need? What do we need if people can't get to work? We knew we're going to have to keep people at night. So we already had cots pre-positioned. We already had rooms identified that staff could stay in. We had asked them to bring their toiletries and any medications you need. We were prepared in that aspect. And really, what about the water? Do we need any additional supplies? Well, earlier in the day, we were really just monitoring what was going on outside. We were getting patients from the floods in our EDs. Our ED was not overwhelmed, but was very busy. And we were not really prepared for all the breaks in the dam that happened, and then especially the water, the Columbia Canal when that happened. So when we got word, really that Sunday afternoon, that the water pressure in our hospital started dropping because of this incident at the Columbia Canal. That was the first really sign to me that that this was going to be bigger than what we thought. We did not really anticipate that would happen. We thought we would get patients and we would take care of them, and we would have trouble getting people in and out of work, but not to have your pressure start dropping. Now, what that means is when the water pressure starts dropping, and it dropped to very low levels, our medical equipment stops functioning because a lot of it is cooled by the water. So if you don't have pressure, water's not getting there. So our CAT scans, MRIs start shutting down. Our IT systems, the room starts overheating, so we have to bring in fans because it's not being kept cool. That started happening, and then you can't flush the toilet. The air starts getting hot. So if you read anything about Katrina, major problem when you don't have air condition, when you have no water to flush, so then you can't flush the toilets, and that starts causing problems. So
I was going to say, let me add, Jay.
Yeah.
One of the things that I didn't know is that water did all that in the hospital. You know, you think about water, you drink it, you flush, but you didn't think about all those equipment that is cooling, all these things that the pharmacy uses. I mean, there's all these
medications.
Places that water is used that I had no idea. So as a communicator, I was like, really? I just didn't know all that was going on. So that was our engineering team. That was one of the first things they came to the table with.
Yep, so that was a big issue. And when we started going down that path, that's when the evacuation word. We thought we were going to completely lose pressure from the city based on the information we were getting from the city and what they were trying to deal with, and they were dealing with a lot. So at that point, we really started talking about, okay, if we have to evacuate 500 patients from Richland, how do we do that and where do they go? Because Providence was full, Lexington really was full as well. The city was full. The Charleston area was underwater. The peninsula was closed off. You couldn't send people there. So you really start thinking about what to do. We had to make some quick decisions that Sunday afternoon based on that. We needed water. So we contacted a water company out of Greensboro and basically made a quick decision. And ultimately it was the right decision because you never want money or finances to guide your decision making, but you're making a big decision about something that's going to cost a lot of money. We did it anyway, which was the right decision. Our water, this company came in and really saved us, but it was about $1 million expense for that water company to come in and provide 15 to 20 tankers full of water, 6,000 gallon tanks of water. But they came in to help us, and then the City of Columbia Fire Department. Phenomenal. They came in that night about midnight. I say they ran sorties, but they ran sorties up Fairfield Road to a pond, pulled water from that, put it in their fire truck, brought it back to the hospital, and pumped it into the hospital to keep our water pressure up so we were able to flush and keep the air going. Now, we couldn't drink the boil water advisory. We learned a lot about this because under a boil water advisory at home, you can take a shower. You can still do some things. You just can't drink the water and you can boil it. In a hospital, you can't use any of that water because you have patients that are sick. You cannot use it. So we had to bring in gallon jugs of water. We had bottled water. So we had to think about giving staff water to drink, having water available to clean hands and to bathe people. So we had to have a lot of bottled water in. All those resources came to us. It took a while to get that, but we were able to pull some stuff out. We had to look at sandy wipes and daycare and a lot of things that we had to go through to plan for that. The boil water advisory really caused the biggest issue. Well, before I get there, this was our goal here that we worked on. This was put up in our command center on day one, and it basically was to not evacuate. So whatever we need to do, we cannot evacuate this hospital. If we had to evacuate the hospital, there's always bad outcomes when you try to move patients. So we didn't want to do that. And then we wanted to provide safe, quality care for our patients. The biggest thing the boil water advisory, besides not having water to drink, and we had to provide that, was really with our steam sterilizers and washers. We could not do elective surgeries, and if you know in hospitals, elective surgeries is a big, drives your economic engine. And we had to go 3 days without doing elective surgeries. We were still able to do emergency surgery. We still had traumas coming in, people coming from other areas that had accidents and whatnot. So we were able to continue to do that, but our elective surgeries had to be canceled. And our main thing was how do we get, we thought originally that we could take the dirty water and we steam it, and it heats to 300 something degrees, but we were quickly told that in a flood
Can't use it.
boil water advisory, you can't do that because there are endotoxins in the flood water that would release and would cause problems. So we had to run new pipes into our steam sterilizer. We had to run temporary piping into our washer area, running water from the tankers that we had contracted with. So our engineering department was phenomenal because they had all this figured out in 12 hours. So we were able to get the surgeries going again by Thursday. So that was huge. We brought in porta-johns around the campus because we knew if we didn't have water, we had to have somewhere to go to the bathroom. So that was a quick decision we made. We brought in probably 50 to 75 porta-johns. The National Guard ended up coming in to save us. They arrived on Wednesday, and they brought in these ROPU units, reverse osmosis purification units, where they take these units anywhere in the world, set up in wherever, and take dirty water and purify it and provide water for wherever they are. They came in, and this is what they had to do for us. They basically took the dirty water from the city, ran it through these units here, and basically cleaned the water, and then we were able to use that water. The other thing we did not, one other thing, the other big process was once our system was contaminated, we had to clean it. So once we got the clean water in, we had to go in and chlorinate. So we've never done this before, and you had to chlorinate a system. We used 300,000 gallons of water a day at Richland alone. So you can imagine all the areas you had to go and clean, and you had to chlorify the system, and then you had to go and test it. So it was a big process. It took a lot of man hours to do it, but we were able to get through it. It was a long process, but it eventually the Army saved us and the fire department saved us. So, and also we had this was all going on at Baptist as well. So Baptist had its issues. Now they have a little older water system, so they had a couple of areas they had to work out of. They did bring in some chillers. They also brought in these water tanks. We brought them into all campuses actually. Park Ridge not so much affected because they were on a different water source, I guess, from the city. They did have boil water for a couple days, but then that was released. So, and we worked really as a system. Each campus, we had system calls where we tried to figure out, could we move patients to one hospital? Can you do this? We ended up sending a lot of our equipment that needed to be sterilized to Lexington Medical Center, who agreed to do that, and that was wonderful collaboration. And that's what we do in a disaster. We depend on each other, and everyone backed each other up. So it was a great, something we didn't want to go through this, but we did, and we learned a lot. And we'll talk about that. So I'll turn it over to
So
Shalom.
Palmetto Health has a number of tools that we use to get the word out, but I'm gonna go backwards a little bit. When the flood started and we got notification, Tammy was not in town. She was visiting her son at West Point. So I'm here in Columbia, in Northeast Columbia, and get the weather, the national forecast that we all got pinged on our cell phones. So, I don't know, it was like 6 o'clock in the morning, 5 o'clock in the morning. So while we plan and drill, I never plan and think about drilling that she's going to be out of town when a huge crisis happens.
But you should.
Yes, you should.
Because the people you need won't be there when you need
That's
them.
right. And we got through it. But I say that to say that, so my first line was to talk to, well, I got up and trying to figure out what was going on since, Saturday I went to bed, it wasn't that bad. But we did get on the telephone. But so for those first, 12 or so hours, Tammy was not in town. And there were a few hours of the day she was not available because she was getting on a plane to fly back. So we managed, and Jay and I worked together, but I was stuck at home in Northeast. So while many people were able to, or several people were able to get into the hospital, thank goodness for communications in various ways that I was able to communicate, talk to them on the telephone, and do things electronically, but getting to downtown was impossible for me. It just was not possible. I tried to talk to several people that said, I tried to get down there, don't even try. So we work things out. But in order to start sending information out, one of our many tools is one of our electronic newsletters that goes out to every single person that has a palmettohealth.org email address. And at the time, there was about 10,000 of us. So we had to figure out what did we want to tell them at that very moment that you're seeing, and who needs to come into work, and when do you need to come into work, and be safe about getting there. So we started that process pretty early in the morning, very early in the morning, and continued to update our team members throughout the day as often as necessary without creating an alarm. We wanted to provide them with the things that were happening at the hospital and within the system as well as the community. We also have another electronic newsletter that goes out to our medical staff. So we tried to make sure that while we blanket our system of 10,000 folks with our Palmetto page is what that's called, we have one directly to our medical staff that had pretty much the same language, but we wanted to make sure one way or another you were going to get the information. And we did the same thing, sending it out to them. At the same time, for the individuals or our team members that were in the hospital that might have had access to a computer, our intranet is called MyPal. So we would post similar messages there. Again, we want to make sure that wherever you are, because you may not be able to check your email, but you may have been on the computer to see something you can get, it automatically comes up, so you'll have our internal website to see. Again, sharing that same information. And then one of the things we had thankfully started implementing last summer was a subscription service called Send Word Now. So it allows those of us that subscribe, similar to that you hear about colleges and universities that send out a message, we need you to do X, or we want you to know, whatever the case is. So we were able to notify team members that had already signed up with that. Similar information. Again, we didn't want to continuously slam you with messages, but we wanted to make sure that you had the message wherever you are and however you got it. And one of the things that we also use is it's called Command Aware. So our emergency management team can get together in crisis and start sending out, and it's a cascading way of sending information and that they can share with you. And there's various ways. For myself, I'm in there so that it'll call me first. If I don't answer my cell phone, it will the next send me a text message. And if I do not respond via text message, it will call me, it'll send me an email, one way or another, again, to make sure that that you will get the information about, we need you to come in, we want to update you about X, whatever's happening, and it's level tiered. Tammy and Jay are at the very top in our Team A tier. I'm a little further down in the chain, but they are one of the first lines of, if I can use the word, defense, in terms of we need everybody to get together and here's what the plan that we need to execute. And I think, I'm not sure, because since I wasn't in the hospital right away, in terms of our overhead paging system internally that we might have used. And we definitely brought in a lot of our marketing team to create flyers and posters for patient trays so that we can let, in addition to our team members know, our patients know, and our guests and visitors that were there with them, what was happening, the restroom situation, so that you know that when food is coming, that there's porta-johns outside, whatever. Again, we needed to share the information. We wanted to make sure you were equipped with it, and we can provide you with the care that you needed while you were there. While we were working on this information internally, we probably simultaneously did a lot of external. So whatever we were sharing internally, we pushed out to media channels outside. We wanted the community to know what was going on, and we wanted our team members to know that may not have been able to get to their email because they were at home or they were dealing with the flood there in their own way. So what was open, what was closed, who was delayed, when we needed you to come in, and all of the news stations and the papers was very helpful in sharing that information for us. We definitely went to social. We all know that social is definitely a way to contact people. So our social media was fabulous in regards to sharing, again, updating everyone what was going on, as well as people sharing what we were saying out there. And you're gonna
look. So part of what we saw for Facebook is we started those first messages at 8:37, and then we the numbers just kind of speak for themselves. That first post reached like 70,000 people. Its reach was because people were paying attention. And one of the things that, I'll say this, one of the things I think that works about it is we are very engaged on social all the time. We have some very engaged people. We're always posting things. So I think because of that and of our large team member population, people paid attention. Let's see what's happening at the hospital. So we had a lot of really good reach, and we had about 29 posts total. So there was a lot of reach there on our Facebook page, and then we have our Children's Hospital Facebook page. One of the things about the hospital is we don't have a lot of different Facebook pages. Right now we have 3. And so we have Palmetto Health, the Children's Hospital, and now we have the Palmetto Health USC Medical Group. So we're trying to keep those numbers slim so that if you're looking for information about Palmetto Health, you can go to one place and not have to look all over the place. And then, of course, Twitter. We had the same thing. We had lots of them. So we had a lot of people following us and asking us questions about what was happening at the hospital based on our social media. One of the things I was going to say, too, and we were talking about earlier, which is not a communications thing, but that was an interesting thing to me as a communicator. We were talking about how when you can't use the bathroom, we had to order all, what's it called, Jay? Sandy
bags.
Sandy bags. So, in Katrina, and it's so funny, you learn things from last. One of the things that happened in Katrina when they didn't have water is they didn't have a way to flush. So then we also had to order all these Sandy bags, which you put in the toilet, which is like kitty litter. So, and you're communicating all that kind of stuff to families too, so that you let them know what's going on. Because that's kind of weird to be in the hospital and have to, I know, but she's like making a face over here. So anyway, that was one of the things that was interesting too, all the supplies that you have to make little things like that work. Because a patient who's sick can't go outside to the porta-john, so you have to make allowances for that. So these are some of the lessons learned. The unified alert desktop system that we use for team members, all the computers didn't have it. So what it is it's a pop-up that'll come up on your computer screen, and it'll give you a message.
And you have to acknowledge it.
And you have to acknowledge that there's the message. This is what's happening right now, which is great. But all the computers, we figured out that all the computers didn't have it. So why don't all the computers have it? So then that was something we learned. During the water purification process, we didn't have enough radios for all our engineering team. They couldn't communicate with each other, so it was a communication issue. Team members reported having problems getting to our intranet from home, so then they were having a problem. What is the best way to communicate to medical staff?
Yeah, and I'll jump in there.
Yeah.
One of the things that I do is I mentioned our medical newsletter. We have, or our medical staff has the option of how they provide contact information for us to get to them. Versus myself, it's my palmettohealth.org email address. So depending on what information you give us is how we contact you. Now, do you check that mode of communication regularly? The answer may be no. So in terms of a challenge, we provided you information the way that you asked us to share it with you, but they may not have checked that line of communication. So how do we fix that? What do we do? Medical staff sometimes is a little busier and different things going on, so they may not be as readily accessible as many of us as communicators, checking all forms of communication 50 million times a day. They're taking care of patients or doing whatever else might be going on, but not checking. So how do we make sure that they get the information? Because we needed them to come to work too, or to take care of patients, or know that at a certain time we're going to need you to come in. So we have to figure out what are we going to do to improve that line of communication with our medical staff.
I'm talking about unified command. On the 296 staff,
Yeah.
It was something we had established where you could call in, just listen to a message, and we hadn't actually used it yet. And so one of the things that we had we were waiting for some IT things to happen with it. So one of the things that lesson learned is that we needed to have that completed. And so now that process is completed, so you could just call in.
Also, our unified command, like I said before, we did run that out of one hospital, but there was some confusion that each hospital didn't really know that they should have their own incident command going and how it flowed up to the unified command. Because this was the first really big disaster we had had where we did a unified command for the system. So we learned a lot about that and learned how each hospital command will flow up through the unified command, and there's some reporting that we will build into that. And
Jay, can I jump in? So some of you may know or think about incidents that have happened around this state, or just you'll watch the news and you'll see all the reporters gathering together to listen to what's going to happen. Well, we do that internally. So our unified command happened to be at Richland where Jay was leading, which is that sign I still love about we will not evacuate. So I'm at home in Northeast. I dial into a specific number several different times throughout the day to listen to what's the latest update, and everyone in other campuses did the same thing. And we at times have had, so that they all have their own, but instead of having a broken down each hospital do it, we're all called in together to listen and get the reports, what's going on at Baptist, what's going on at Baptist Park Ridge, and then Jay leading what's happening at Richland and system-wide. So again, we have one form of communication coming out as a report so we can all hear it at the same time.
And just to say, Jimmy's in the room, but I wanted to comment on the South Carolina Hospital Association, was also involved in those phone calls and ran a state. Got all the hospitals in the state areas were affected, so they were very involved and engaged in helping us as a hospital, group of hospitals to work better together and helping us coordinate with DHEC and CDC. So again, kudos to them. And I'll quickly wrap up because I know we're running out of time. I went through, there are other lessons learned, but the one thing around utilities, the one thing we are doing is a couple years ago we had someone come in and look at what is the possibility of us finding water on our campus and to do a well. Of course, it was a lot of money and there's always demands for money, and we opted not to do it. Well, guess what we're doing now? We're starting to drill to see if we can find water. We don't know, there's a 50% chance we'll hit water, but it would have been a good source of water. It won't take care of all of our needs, but it will help, and it will be there for us for the next time. And then quickly, the impact on Palmetto Health. The total loss with revenue and expenses was between 12 and 15 million. We obviously have business interruption insurance. We're going through that process now to fix all that. At Richland, we spent about $2 million in extra expenses to address the flood. And that's the water contracting, the porta-johns, the chlorination process. I mean, there are a lot of things went into this, but it was an impact. You know, we had some decrease. We lost some patients who had things scheduled and they needed to move on and have things done. But we got a lot of that back. But a lot of loss from doctor's office visits and ER visits that you would normally have that went elsewhere. So anyway, that's where we are now. We have rebounded, and we're preparing for the next event. So
In 100 years.
Yeah, the next. Yeah. We'll be here in the next 100 years.
100 years from now.
That's it.
Okay,
Thank you.
we're going to take questions now. Anyone have a question in the room? If you do, I'll come to you.
That's good.
Anyone?
Well, I have one.
Okay.
Y'all might have addressed this, so I apologize. I know with like the media, I'm sorry, yeah, we are recording. I know with like y'all were in a group, but who is the person, is there a staffing person that knows that which floor, it's like how are y'all doing that part too? I know there may be a blanket email that says, hey, we need you to come into work, but who realizes that this nurse in this department needs to come in and she's not here? Like who's doing the employment part on the floor?
So all that information is funneled to the command center. And any staff shortages would be communicated to us, and then we would be responsible to get information out of, we have a labor pool set up, so extra nurses are coming in or extra doctors. So if we needed to assign one to one of those floors, we can do that. So.
Just one follow-up.
And we do ask for people to check in when they come in to make sure we know everybody that's in the hospital. too.
Okay, and
So-
what if you have a situation where, like, let's say the flood was totally around the hospital and nobody could get in, you only had the staff that was currently there, what's the emergency?
That's who would be working.
Okay, so they just have to stay and keep going? Okay.
Correct.
Yeah,
And
and
we
we-
would try to rotate people based on what was going on. We did discharge a lot of people, but we still had close to 500 people in our hospital, and it fluctuated a little bit, 50 or so patients a year. But we did move some patients to Lexington. We moved some patients to Park Ridge. So we were able to decrease the demand for services, and that's really what you have to do during a disaster is because you really want to conserve whatever resources you have.
So we have a question from our friends in the Low Country. This is Chris Duncan. This is for Tammy and Shalama, so I think that this will be good. What is the most important takeaway you learned about crisis communication during your response to the flood?
I think it's what we planning, just making sure we practice and plan. I will say that the media was really helpful to us, because one of the lessons learned that we didn't talk about was an essential versus non-essential. There was a big question about, there was some language being used about who was essential and who was non-essential when you're talking about caring for people in the hospital. And what ended up happening with that is people who you didn't think about that were essential were like, just say registration, admissions people. Well, if you have patients that you need to get in, the nurses aren't going to do that. So everybody really is kind of essential. So we got back down to saying, yeah, we really need everybody to come in, and if that's not your job, we'll get you to do something else. If you can get here, come.
Safely.
So safely, yes, safely, if people can get here. So I think really it is planning, making sure that you've planned, and really coordinating with the media. I mean, we had some requests come in for some interviews, and so we had some of our docs come out of the building and come out by the water tanks to do those interviews, even though we were in a crisis, because we were trying to respond to them because they were helpful to us. So the back and forth.
I love my hospitals are asking questions online. This is great. So MUSC has a question from the PR department. They said, please give examples of what did you communicate, what type of messages did you communicate to patients and family members?
That's good.
Part of what when we were doing about the water, we made flyers and things that we had to use paper products for people to eat. So you didn't have nice trays and all that. So we were letting them know that they will be using paper products. They were disposable. We were letting them know about the bathroom situation, why they had to use the sandy bags, all the kind of information that why all these exceptions were being made, and that we were going to do our best job to take the best care of them that we could under the circumstances.
Yep.
Question back here.
I know you said the unified command was one of the challenges that y'all were facing during the crisis. How has your training in unified command changed since the flood?
So we did, we have talked about how each campus really needs to set up their own incident command center for that campus and be responsible for communicating specific information related to that campus. So what was happening on the Baptist campus may have been a little different than what was happening on the Richland campus. So that each command center was responsible for that. And there is one person that needs to be the incident commander for each hospital. And then the unified command or the system command would be one person as well. And that was, I played the system commander. My physician executive played the incident commander for the Richland campus. So I had to keep a system hat on, even though I'm at Richland. So we've worked through that and what information we would want each campus to send to us that would impact the system. So when we had our system calls, each campus would report out X number of patients, where they were with getting clean water connected, or where they were with any major issues that were going on. We would do a staffing update if they needed staff. We also had our medical group involved in that. If they had, of course, they were updating us on which doctors' offices were closed, which were open, and whatnot. So we learned that. The other thing we didn't do, after each of those system calls, we had them every 4 hours. We really didn't, if we had to do it again, we would come out of that meeting with a list of things we needed to communicate to the staff. Because the staff, even though we were communicating with the staff every 6 hours or whatever, they still needed to know there was a lack of information coming from that meeting. They knew a meeting was going on and things were being decided, and we just didn't, we should have sent out an internal memo of, here's the latest.
Because what was happening is some of the leaders or the nurse managers were really good about going back,
And
getting with their
communicating
whole
that.
staff and saying, okay, this is what we need to do. And then others would just talk to maybe specific people who had a role. Well, their entire staff wouldn't have that information, whereas this nursing unit or this department, they would because of their leadership style. So what we figured out is that we need to do a better job out of those meetings saying, this is kind of what's happening, the bullet points.
Yeah. We need to decide what that message is, because it changed from what people heard on the phone to what they communicated back, and we needed to take control of that. So that was one big thing we learned.
You mentioned Katrina. I was actually on the ground the day of as a journalist, and one of the things that we learned was that all communications didn't work other than text messaging. Our Nextels didn't work. Satellite phones were having issues. What for y'all was the major Was it a piece of communication that worked effectively with everything? Or was there a set of influencers that you were able to disseminate information to get out quickly? What did y'all find worked best? Or is there not something that really worked the best?
I don't know that I would say, being internal at the time, that there was one thing that worked the best, because we used several
I think I
vehicles because we weren't sure the capabilities or abilities of those, not just of team members that were working in the hospital, but if you were outside of the hospital, we had no idea if you were going to be able to get your email, or if you had electricity, or if your phone even was charged, or if you had a phone. So that's why we made sure we did our electronic newsletters, but we reached out to the media, because typically, as again, bearing where you are, and if you had a house, and if you all those kind of things, you would definitely at least turn to the media, if nowhere else, to get messages. Of course, we want them to come to us as their employer, but if you couldn't get to us, where would you turn? So, we definitely relied on the media, I would think, to be one of our biggest ways. Hopefully, some of those things will change in terms of our challenges, in terms of our SendWord Now, that unified system that colleges and universities and other systems use, so that this way you can get a text message. We're not completely there yet, but I think if we had to say one, I really would say it would be the media, even though we used our channels the best that we could. We just weren't sure who was able to get them at the time.
And we're really stepping up our efforts to get people to sign up for SendWord Now, because at a university, you have to sign up. I mean, it's part of the process. And I think when we did this back in October, we had 3,000 people signed up out of 10,000.
10,000.
I think we're at 5,000 now.
Right.
So now we're taking it to the leadership level to basically say, okay, we need you to help us go to everybody, because it's important that they are a part of it and can get this information. And really what we're most concerned about is an active shooter in the hospital.
Right.
Yeah. And again,
We can do an overhead page, but we need to be able to communicate with them immediately, and they need to be able to get the message. I think they're worried that they're going to get stuff from us all the time. And we're very sensitive to that we don't overuse one method, because even the unified alert that comes out over the computer now, I think people are now, because we send it when there's a shutdown, or we probably send it too much. So then people get it now, I think they just acknowledge it and don't even read it and move on. So if they do that with an active shooter, then that could be bad. So.
Jay, Tammy, and Shalama, thank you so much. This has been a really insightful, thought-provoking conversation. It's just such an important piece of what we do as communicators. So please join me in saying thank you to Palmetto Health.